for that kind introduction. And thank you very much, GGMC, for giving me this opportunity to present today. So, for the next 30 to 40 minutes, I will be discussing on the value of a genomic result in rare disease patients through my experience with Sri Lankan patients. This is the overview of my talk. So I will briefly introduce into rare diseases, and then we'll discuss the challenges when we are dealing with rare diseases. Then I will take you through six interesting case scenarios from real Sri Lankan patients, followed by the value of the genomic result in each of these cases. And then I will briefly take you through some take-home messages. So, as we all know, by definition, rare disease is a condition affecting less than 1 in 2000 people. However, this definition could vary from region to region, and individually they are rare but collectively common. And looking at the figures, though they are rare, the burden is huge, where there are around 300 million individuals affected worldwide with some kind of a rare disease. And at the moment, there are over 7,000 rare diseases, and the list is growing. And when we come to the etiology, so in majority, the etiology is genetics, but infections and immunological abnormalities could also implicate in rare diseases. And diagnosis of a rare disease is a big diagnosis for the patient as well as the carers and the family because of the lifetime of complex care they are entitled to with the diagnosis. Sorry. So, when we are discussing about the challenges in diagnose in rare diseases, getting the right diagnosis is considered the topmost challenge by patients as well as healthcare professionals. Apart from that, lack of awareness among healthcare professionals about rare diseases and accessibility to specialist care and treatment and poor coordination of care are also considered the challenges in rare disease management. I think these are like common challenges in any part of the world, but there could be some minor variations to it. And now, when we take patients with rare diseases, usually a majority of them undergo a period of diagnostic odyssey, during which time they encounter several medical consultations, an array of investigations. However, with the development of investigations and the technology, this time period is narrowing. And at some point in most of them, we think of a genetic diagnosis and they undergo genetic testing, which gives rise to a genomic result. So, is it only the diagnosis of the rare disease that is being provided by this genomic result? But it's not. So, this genomic result, the value of it extends well beyond the mere diagnosis. So, let me take you through the cases to illustrate this. Now, the case number one. Now, this boy presented with chest pain on exertion. And actually, this chest pain was very atypical, and examination wise, he was unremarkable. Now, in a usual 15-year-old boy, this kind of an atypical chest pain we would disregard. But what struck us was this significant family history, where there had been a tragic death in his elder sibling at the age of 6 years. So the story was like he had been a completely normal child up until this age. Then on one day when he was coming home from school, he had come running. And then on the way, he had developed shortness of breath, which had progressively worsened. And they have initially thought it's asthma, and he was being managed as asthma. But on the way to the local hospital, he has passed away. Now, it was a very sudden event, and post-mortem was not done since the parents have not consented. So, until the presentation of the consultant, the diagnosis remained unknown. but it was very suggestive of a sudden cardiac death. Now, due to this concern, this particular child underwent an extensive cardiac evaluation, which did not reveal any abnormal findings. However, now there was the possibility of an inherited arrhythmogenic condition. Therefore, he underwent whole exome sequencing, which confirmed him to be having RYR2 gene pathogenic variant, which implicates in catecholaminergic polymorphic ventricular tachycardia. So, as we all know, it's a lethal arrhythmogenic condition where patients develop um, lethal arrhythmias, most typically bidirectional ventricular tachycardia, leading to sudden cardiac death. Now, so this diagnosis was very well fitting with the death of his elder sibling as well. So now here, actually, this genomic result ended the diagnostic odyssey to the family. And then, most importantly, we were able to provide a risk reductive treatment. He was started on beta blockers, and we were able to offer predictive testing or screening for the other family members. And then in the future, this genomic result would aid in reproductive decision making for this child. Okay, so let me take you through another case scenario. Now, this girl, she presented to the neurology clinic with walking difficulty and deterioration in school function, which had developed over a period of 2 years. And when we examined her, she had bilateral partial ptosis, vertical gaze palsy, cataplexy, bilateral cerebellar signs, and significant cognitive impairment. And now, with this clinical picture, we strongly suspected a neurodegenerative process, most likely due to genetic cause, considering the long history, which was reinforced by looking at the family history, where there were two female elder siblings who have passed away around 22 and 18 years of age with a similar progressive illness. They have also undergone an array of investigations, and however, no proper diagnosis had been made, and genetic testing was not done at any point. Now, with this particular girl who was 17-year-old at that time, underwent several investigations, including hematological, biochemical, then CSF analysis, MR imaging of the brain. And what was remarkable was the bone marrow biopsy revealed CBLO histiocytes. Now, having these lipid-laden macrophages, we and the clinical picture also, we strongly suspected Niemann-Pick type C disease, which was confirmed with the whole exome sequencing. Now, here, if you look at the value of the genomic result in this case, obviously it ended the diagnostic odyssey to the family, which was a very long one. And then we were able to start this patient on miglustat, which was really important for her to actually she improved. The neurological disabilities were improved with the treatment. And other thing was like for the parents, we were able to give a proper trajectory of the disease and explain this neurodegenerative process and properly counsel them. And the other thing is like in Sri Lanka, actually for rare disease drugs, the accessibility is not so great. But with the genetic confirmation, actually, it was easy to get the government funding and also arrange better coordinated care in a holistic approach to this girl, which actually improved her outcome. Okay, let me take you to my third case, which is a different case scenario. Now, this was a 33-year-old primary mother. She presented in her 34th week of pregnancy. The concern was ultrasound of the fetus revealed polyhydramnios, extended attitude, and query of a fetal foot drop. So here, the obstetricians were concerning whether there's whether the fetus is affected with some kind of a genetic muscle disease. And when we dig into the history, mother was also having a walking difficulty, frequent falls over a period of 2 years, which had worsened during the pregnancy. And surgical history revealed she had undergone bilateral cataract surgery at the age of 25 years, which was very early actually. When we examined, she had bilateral partial ptosis with very mild foot drop and proximal limb weakness, and I strongly suspected myotonic dystrophy type 1 here because of the effect to the fetus and considering her phenotype. And when I specifically looked for the percussion myotonia on the thenar muscles, it was evident. And I think hope you can appreciate looking at her. There is bit of frontal balding with a myopathic facies, and the limbs now similarly the upper limbs did not have much of wasting. However, you can appreciate the wounds due to multiple falls she has had. Now, she has undergone a few EMGs before because there were two or three neurology encounters. However, she had not adhered. And then in those, the myotonia was not evident. But since with the whole picture, we strongly suspected myotonic dystrophy, so we specifically asked to look for myotonia, which was evident this time. So what could have happened was like with the pregnancy, this myotonia could get worsened. So this time it could be evident, and however, she underwent the genetic testing, which confirmed the diagnosis. Now here it ended the diagnostic odyssey, and now most importantly, luckily actually we were able to get the diagnosis by 36 weeks of her pregnancy. So there was time to get prepared for the risks involved. Now when we take myotonic dystrophy type 1, when we take a pregnant patient, there are certain risks like prolonged labor, postpartum hemorrhage, and type 2 respiratory failure. And when it comes to an affected fetus, so once born, there could be again respiratory failure. And now there is obviously the repeat number has increased in the baby, so that there is the possibility that he or she could be severely affected. So therefore, with the genetic confirmation, we were able to predict the risks involved to the mother as well as the baby, so that we arranged a multidisciplinary meeting involving the neurologists, obstetricians, medical ICU team, all the intensivists, including neonatologists, so and the neonatal ICU care team. So all were prepared well in advance with regard to the mode of delivery and the intensive care facilities. And most importantly, we discussed all the possibilities with the patient as well as the immediate family members, so that they were also well informed of the possibilities and prepared. So actually, this enabled us to provide a coordinated specialist care to this patient. And in the future, for these kind of couples, this will be really important to take reproductive decision in the future. So coming into actually what happened now after the delivery, though it was planned to be a more normal delivery, but however it was a prolonged delivery, and we had to deliver the baby via emergency C-section, and the mother went into type 2 respiratory failure, where she couldn't be weaned off from the ventilators, and she had to be in the ICU for a prolonged period, like 3 to 4 months. And luckily she survived but had to undergo very prolonged period of rehabilitation. And when it comes to the baby, the baby was very hypotonic and again in respiratory failure. So after 4 days, there was sepsis and he passed away. So actually it was a tragic story. So looking at it, though we provided the best available care for them, I think in the ideal world, what could have happened was if this genomic result was available pre-pregnancy, then the couple could have given a pre-pregnancy counseling and gone for a reproductive uh, option after the information received, so that the story would have been a better one. Um, so, okay, let me take you to another case. Now, this patient has a very long history. So, at the age of 14 years, he presented. However, the history began in when he was 3 years, where there were frequent falls and walking difficulty, which had progressed. So, at the time he presented, he was wheelchair bound. And on examination, there was bilateral partial ptosis, proximal limb weakness, limb wasting, and the family history was very significant. There was no consanguinity, but his elder sibling had a similar phenotype, but a lesser, to a lesser degree. He was actually ambulant with support, and with this, since the toddler ages, they were evaluated and managed as limb girdle muscular dystrophy. However, what was not keeping with it was the normal CPK values throughout. So at this point, this child underwent whole exome sequencing, which confirmed DOC7 type congenital myasthenic syndrome. Now here, it was actually very important diagnosis, which gave an optimistic and a new hope to the family actually, because like when we take the treatment spectrum of myopathy to congenital myasthenic syndrome, it's totally different. So here, like from where there was no treatment, we were able to offer these two children a treatment where they were started on fluoxetine and salbutamol, which drastically improved their neurological disability. Where actually the elder one was able to walk independently and attend to everything without any support. And the younger one, actually, since he was wheelchair bound, there was a lot of disuse atrophy, but there was significant improvement and still he is under rehabilitation. And on the other hand, in diseases like congenital myasthenic syndrome, it's very important to have a precise diagnosis because, like, different types have different risks. So, certain types like COLQ, CHAT, and they have a high risk of respiratory crisis. And when we take COLQ type, they have high risk of going into chronic hypoventilation. So, these kind of risks can be predicted and can be actively looked for, and they can be managed very successfully. And other thing is, uh, um, other benefit is to avoid harmful treatment, like for DOC7, COLQ, and slow channel types of congenital myasthenic syndrome. If they are started on neostigmine, pyridostigmine, which are the conventional treatment for myasthenia, it would have worsened the condition. So, and finally, like for proper counseling, for specialist care and coordinated care, this genomic result was very important. Okay. Now let me take you to another case. Now, this boy was at 10 years of age. It was an acute presentation where he presented with acute onset altered consciousness and abnormal eye movements. Actually, it was like a seizure-like episode he presented where there were right-sided brief jerk-like eye movements, which were like in between he regained consciousness. So they were occurring at a frequency of about like each episode lasted for a few seconds, and they were occurring for a duration of 15 minutes. Like so, after the initial acute management, like seizure, where he was given anti-epileptic drugs and supportive treatment, the one stabilized when we examine. He was short statured with significant muscle tenderness and proximal limb weakness. So, in this scenario, what was initially thought was whether this is some kind of an infection or a immunological process or a metabolic derangement. So, he was extensively evaluated. However, the striking investigations were elevated CSF lactate level and highly elevated CPKs. And when the brain was imaged, there was an occipital infarction. And interestingly, his mother has had a similar presentation 6 months back. So at that point, she was 36 years of age, and her MRI was also having an occipital infarction. But however, she was still under evaluation when the child presented to us, so the diagnosis remained unknown. So with this family history and the presentation, we strongly suspected MELAS, mitochondrial encephalomyopathy with lactic acidosis and stroke-like episodes. So he underwent whole exome sequencing with mitochondrial sequencing as well, which had an interesting finding. So it confirmed MELAS. And apart from that, actually, his nuclear genome sequencing revealed another finding that he had pathogenic variants for the NEB gene, which implicates in nemaline myopathy. So, however, we concluded that he has MELAS, and he and his mother. And there was the possibility whether he has coexisting nemaline myopathy. However, to confirm it, he should undergo muscle biopsy to look for nemaline bodies. But the parents did not consent, and also the other thing was like which prevented us from doing it was the lack of added therapeutic benefit and considering the invasiveness of the procedure. So it was abandoned. However, we still thought that there is the possibility of nemaline myopathy also coexisting, considering this elevated CPK level, which is not very well in keeping with MELAS. But still, like MELAS could also give rise to proximal myopathy, but we would not expect like this amount of elevated CPK. So still, it's a bit of a doubtful situation whether he has this nemaline myopathy or not. But however, what this result showed and this case taught, at, taught us was like sometimes two entities could coexist and they could alter the clinical presentation. Um, Looking at this case, actually, it gave an accurate diagnosis for the mother as well as the child. And then, most importantly, like we were able to offer treatment for them. So they were started on coenzyme Q, creatine, carnitine, and especially arginine, which was beneficial in preventing stroke like episodes. And we were able to predict the risks and advise them, as well as the medical team looking after them, how to manage acute situations like infection to avoid this kind of metabolic crisis in them, and to avoid harmful treatment. This was beneficial. And finally, like we were able to counsel them well. And also in this case, also drugs like arginine are not easily accessible to patients in our part of the world. So this diagnosis improved the care in a major way to these two patients. Okay, now looking at my last case, this was a 2-year-old boy who presented with failure to thrive, bowing of legs, and abnormal head shape. Now, examination revealed his weight and height in the -2 SD and -3 SD range with dolichocephaly, right eye proptosis, genovalgum varum deformity of the lower extremities, and overlapping toes. So here there was a suspicion of some skeletal dysplasia, and the bone profiles revealed low vitamin D level and elevated PTH level. Now here, the first two images shows the abnormal head shape of the child, and looking at the CT and MRIs, there was multisuture craniosynostosis in the coronal and sagittal sutures, and there was right-sided encephalocele extending to the right eye, leading to the proptosis. And family history, actually, there was no consanguinity or affected other members. And he underwent whole exome sequencing, which revealed him to be having a paternally derived pathogenic variant and a VUS of maternal origin in the CTSK gene. Actually, the parents and this patient underwent trioexome sequencing. So here we confirm the diagnosis of pycnodysostoses, where we thought this VUS is, we considered it as a significant one, considering the clinical picture. But the interesting finding was like this craniosynostosis is not a typical feature of pycnodysostoses. But however, with the genomic result, we were able to confirm and give an accurate diagnosis to this patient. So How it benefited was like with this, like we were able to provide him a better coordinated specialist care where he underwent a neurosurgery with the oculoplastic surgery as well for the encephalocele, and vitamin D was replaced. And at the same time, their parents wanted to know more about the disease, and they had concerns like whether there could be effect to the intellectual abilities. So we were able to like educate them properly, and also like since they were a young couple, they had fertility wishes. So properly, we were able to give counseling as to the reproductive options. So finally, taking the whole picture. So this in rare diseases, the genomic results are really important to arrive at accurate diagnosis, which aids in providing precision treatment. And so that is in an individual perspective. But when it comes to on a global scale, they are very important to enhance awareness among clinicians and also patients, and for the advancement in research and therapeutics for the rare diseases, and finally for the policy making. So these are my take home messages. Rare diseases are collectively common and they account for high morbidity. And the value of a genomic result extends well beyond the provision of accurate diagnosis, and most importantly, for the provision of precision treatment, accessibility to the drugs, and better coordination of care. And on a global scale, they are very important to overcome challenges in managing rare disease patients. And finally, I would like to acknowledge all the patients and their families for giving the consent to share these details with the audience, and all the clinicians who were involved in managing these patients. And special thanks goes to staff of Human Genetics Unit, Faculty of Medicine, University of Colombo, for the provision of the genetic testing, and especially Prof. Vajra Disanaika, Dean, Faculty of Medicine, University of Colombo, for his unwavering mentorship. And thank you everyone for your patient listening. And I would like to answer any questions if there are any.
Thank you, Kawmadi, for that very informative presentation. There is a question in the chat box. It says, could you please explain the current landscape of Sri Lanka's involvement in international rare disease initiatives? Specifically, are there collaborations in place that enable Sri Lankan researchers and clinicians to access genomic data from outside the country? I ask since such access may enhance the value and application of local genomic research and clinical efforts, especially in rare diseases.
Okay, so to my knowledge, like we are involved with rare disease projects in collaboration with G2MC, and also like when we are managing rare disease patients, like we provide this data to the international databases, especially the ClinVar and GeneMatcher. Kind of we collaborate with the databases as well. So those are the ones to my knowledge. Maybe Dinesh Shani, and if Prof. Vajra is
Yes, to add
available,
to that,
you
we are
might be
also
able to add. Yeah.
we are
Yeah.
also part of the Undiagnosed Disease Network International, and we participate regularly in undiagnosed hackathons also, which started last year. We had submitted a patient this year, so those are collaboratives that allow us to share data of our patients and also access data from international databases that are mostly universities that are not accessible otherwise. Hope that
Hi,
answers your yes.
can I ask a question?
Sure.
Okay, my name is Dr. Ricky Steuerman. I'm a genetic counselor and a lecturer at the university in Israel. I wanted to know if there are any genetic counselors in Sri Lanka.
We don't have professionally trained genetic counselors. So actually, in the absence of them, so actually the geneticists provide the genetic counseling as well. But we are in the hope of starting a standard training course for the genetic counselors in the near future. Yes.
That's amazing news, and I would like to offer my services. I can give some lectures.
Oh, thank you
Since
very
I
much.
do
Yes,
teach the
that's really
profession in
nice.
the university here.
Okay,
So
thank you very much.
we're happy. I can write my email in the chat for you.
Oh, okay.
Thank you. Are there any more questions? So, in the absence of questions, I would like to ask one question, Kawmadi.
Yes.
When you did the mitochondrial genetic, did you look at the entire mitochondrial genome, or did you do a hotspot sequencing in the Malas patient?
That one was entire mitochondrial genome that we did.
So, thank you very much. So, in the absence of any further questions, I would like to conclude this session. Thank you, Kawmadi, for joining us today, and it was very insightful. And Latifa, do you have any other formalities to fulfill before we conclude?
Yeah. First of all, thank you so much for moderating this session, and thank you, Kawmadi, for the insightful presentation. Please, I want to thank also the audience for their participation. Please stay tuned for the upcoming GGMC webinar presentation for the next month. We will keep you posted. In the meantime, I'll hand it over to Scott to give you some information also about the upcoming conference in ICC conference in Singapore. Back to you, Scott, please.
Hey everyone, I'm Scott Sunseth. I'm the director of the International Health Cohorts Consortium, which is one of the two consortia that makes up the GGMC, along with the G2MC group. We have a conference coming up in August in Singapore. I put the website and registration information in the chat, but there is a session on rare diseases at that if you're interested in attending the conference. There is not a hybrid option for the conference. It is in person. I apologize for that, but that was the only way we could do it. It should be a very interesting conference overall. It'll cover everything from cohorts to clinics is the byline of the talks, and you'll see that we do everything talking about translational discovery of new genes, as well as talking about implementation of genomics across the world like we heard today. So please take a look at that conference website. If you're interested in attending, you can register there and find out about all the talks that'll be available. And thank you for attending this webinar today. We really hope it was helpful for everyone.
Okay, thank you so much, everyone, and enjoy the rest of the day. Bye-bye. See you next time. Bye-bye.
Bye, everybody.